Okay, let's spend a little bit of time talking about Chapter 1, an introduction to pathology. Much of this is going to be a review. Here's the learning objectives that I've identified for us. First off, define some common terminology associated with the study of disease. So if you have your textbook, if you already purchased it, you're going to notice one of the things that's nice about this is it's in blue. As you're running through it, the stuff in blue is the stuff for you, right? We need to differentiate between signs and symptoms, diagnosis and prognosis, benign and malignant, carcinoma, and sarcoma. And there's a lot of this versus that way of thinking about this stuff that's going to be important. In fact, that's what comparative means. Kind of the most broken down way of talking about what a comparative way of thinking is just this versus that, right? And so in case presentations for radiologists, they talk a lot about this versus that. Like it could be a lymphoma, it could be this other thing. And then we need to describe different types of disease classification. So the major way that this textbook is organized is based on disease classification. So each chapter kind of marches you through the different classifications of disease apparent for the abdomen. So here's some general terms for pathology, right? Pathology just means the study of disease and disease processes. Disease then is abnormal disturbance of structure or function. So again, if I know what a normal ear looks like, right, I know when something is different about the ear, either functionally, the way the ear is hearing things, which is difficult to measure, or structurally, how the ear appears. Okay? Pathogenesis just means those events that lead to disease. So for this individual, being in unsanitary environments, right, going to certain countries in the world can lead to an ear that has these structural and functional changes, right? Manifestation, we will call these the observable changes. There is something going on with this ear. I don't know if you can see it, but there's little dots or little bumps around the outer canthus of the ear, right? What's going on? I would call those manifestations, right? That's kind of an umbrella term. Beneath that umbrella term, we have two other terms that I've asked us to do some this versus that thinking about. So these are important this versus that thinking things. I even see this error in papers in journals, right? So this is a significant distinction to make. A symptom is subjective. It's the patient's perspective of the disease. I don't know, my ear just feels weird is subjective, right? There's no way for me to measure the weirdness with which your ear feels, right? But there's a lot of things that are significant symptoms. For example, a headache. I don't have a scale for measuring headache, but is it significant? Yes. What is it? It's a symptom. It's a significant symptom, possibly of all sorts of things. A sign is something objective, and it means it's detectable with examination. So interestingly enough, as science progresses, as the field progresses, we are able to detect more things, right? So just recently here at the college, we've created a neurodiagnostics program, right? That's some of the folks that are going to be in our old classroom. What are they doing? They have ways of detecting things like seizure activity. We didn't used to have that, right? So we couldn't tell unless there was the exterior observable manifestations of a seizure, whether or not someone was having a seizure. Now we can use electrodes to make observable changes. We can make detections of that seizure activity. So that would be a sign. So a sign for this individual would be if we do a blood test, we find something like leprosy. So this is one of the manifestations of leprosy, right? That we have these change in the structure and function of the ear. If we do the lab test and we see that there's leprosy present, then we have a sign leprosy is what's causing the changes in this person's ear, right? Now, with leprosy, there just wouldn't be the blood work. There would be a lot of other things going on with the individual as well. We'd start to see some unique rashes that are related to the disorder. We would start to see stuff like the skin sloughing off, some pretty significant changes in the person's life and ability to function. We would call those things a syndrome. So around leprosy, there's a whole lot of things. People can lose their nose based on the cartilage changes that occur with leprosy. So one way to think about this is that it's like a constellation of signs, right? That all of them indicate leprosy. So a lot of times what we're doing as x-ray techs is we're contributing at least a few of those signs, those observable things, to the overall constellations of diagnosing something related to its syndrome, related to its common signs, right? So we're just part of the process. Why? Because we're looking for a constellation of signs. So I really do look forward to teaching y'all every day. I enjoy interacting with y'all. I learn something every time. I learn a lot. Okay, etiology is the study of disease cause, right? So it's important in thinking about this. We'll have another this versus that thing here in just a moment. But etiology, what caused the disease, right? Was it bad drinking water? Was it eating all these fried foods? What caused it, right? Now, unfortunately, there are things that we can cause ourselves within the healthcare system. So there's two things that we kind of need to do a this versus that thinking about. The first is nosocomial. This is stuff that's acquired, an infectious process that's acquired within the hospital, right? And this is real. This affects a lot of people. In fact, the most recent data I saw is that it's the 8th leading cause of death in the United States of America, is hospital-acquired infection or disease or trauma. So nosocomial is those infections like MRSA, right? Iatrogenic these are adverse responses to medical treatment, right? So we caused harm while we were trying to treat the patient. So an example of that we probably have all heard stories about, but I think a lot about is, with Dr. Death. This guy was doing spine operations. Why? Because people had lower back pain. So he was trying to treat their lower back pain, but he was botching the surgeries. So that would be an example of an iatrogenic interaction where they're trying to treat the spine injury and causing further injury. Idiopathic means we can't determine what the cause is. One of the most common idiopathic manifestations of potential disease is a headache. People have a headache. I don't know what caused it. Is it stress or is it a stroke? Those are two very different things requiring very different treatments, but it's difficult to isolate that. Another like this versus that thing, which we should be pretty familiar with, is acute versus chronic. Acute is something that has a quick onset, and generally it resolves itself fairly quickly too, either in death or continued life, right? So we fall and we break our arm. That's an acute trauma. It will repair itself fairly quickly, right? Fairly quickly, within a matter of months. Chronic is something slow. It's going to come on slow, and it's going to stay a lot longer. In fact, it may be there for the rest of your life, right? And then sequelae or sequelae, either way you can pronounce it's fine by me. These are, if you think about sequences of events, right, like sequences in a movie, these are a sequence of infectious processes that contribute to a problem, right? So leprosy, I mentioned earlier, there's a sequence of events in leprosy that contribute to further problems, like things like losing your nose. Another example of sequelae would be like with HIV. If we're tested for HIV, we have HIV, that can lead towards a sequence of events, including certain tumors within the body, right? Other disease processes, pneumonia, right? So impaired immune response leads to other problems, right? All right. Yeah. Okay. Diagnosis means that identification of the disease. We can say, yes, I believe that you have fractured your arm, right? There's arguments to be made that diagnostic imaging, there's really nothing diagnostic about diagnostic imaging, right? What we don't really diagnose very much. We say things are suggestive of this or suggestive of that, and then we refer for further testing related to that suggestion. But there are things that we can diagnose. Prognosis. This is like looking into the future and saying, okay, within a few months, your injury should be healed, or we're going to have to continue to take this medication in order to treat this. That's predicted outcomes. All the stuff that the patient listens to and then does the complete opposite of, right? Morphology is this structure of cells and tissue. And it's important to us because morphology is going to be what we are most interested in as X-ray techs. It's probably not a term that you're super familiar with, but it is the major thing that we're trying to picture, right? Is morphological changes, right? How the disease added to tissue or how the disease subtracted from tissue, because that's going to be what's most apparent on X-ray images, on CT images, on ultrasound, on MRI, on all of those. We're looking at how it affected structure. With nuclear medicine, we can look at physiology. We can look at how it's affecting function, right? But it is kind of the exception that proves the rule. For the most part, really what we're doing is morphologic imaging, right? We're imaging changes to structure. Epidemiology is that term that I said, there's a little bit of a this versus that with that in etiology. So etiology I said is what? Good, and cause of disease. Epidemiology is looking at that across a population. So how many incidences of tuberculosis occur in the United States versus, for example, Honduras or Tibet or London and England, those types of things. Those would be epidemiological studies. Part of how epidemiology works is it looks at prevalence, and so that's the number of cases found in a population, right? And that population can be defined by location, it could be defined based on a person's sex, it could be defined based on age or ethnicity. All of those things can be used to determine a population, right? So for example, trauma, injury, right, is more common in a younger population than in an older population, right? So its prevalence is higher with youth than with older population. Incidence is just that number of cases over time. So I want to this versus that real quick. With prevalence, number of cases in a population. Incidence, number of cases over time, right? Have you ever had those nights in the ER when it's like it must be a full moon? And lo and behold, it is, because it's like we just literally had 5 people stabbed by a knife, right? It's like either like there's a sale on knives and knives are falling out of the sky, or it's a full moon, right? We would call that an increased incidence, and arguably based on lunacy, right? That's what that term means. It means influenced by the moon. A lunatic is someone who is influenced by the moon. Lune is both the Latin and the Spanish word for moon, right? So people have recognized that significance of the moon for a long, 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 long time. I will not be the person that dispels that.
It's not gonna happen until 2029, so get it while you can.
Go a little bit quicker now. Mortality rate versus morbidity rate. Mortality rate is just the average number of deaths. Morbidity is those patterns in mortality rate is based on patterns in medical interventions. This is what the National Center for Health Statistics is looking at. Morbidity rate is the incidence of sickness that interferes with daily routine, right? So as you're struggling with an illness, they may say this illness has a significant morbidity, which means it's going to significantly affect the way that you do everyday life, right? We spend a lot of money on healthcare, right? The most recent data that I saw, and this is from the textbook, is about 18% of the gross domestic product is spent on healthcare, right? That's roughly $3 trillion, right? That's annually for 2014. This is funded by the government, it's funded by private insurance, and it's also funded directly out of people's pockets. Anyone familiar with this movie? To us, so most impactful to us has been the increase in visits to the ED. It's particularly important if you realize there was no such thing as an emergency department prior to year 1967 or something. There was no such thing as an emergency department. So it has radically changed the way that we do medicine. So I remember being out at St. Francis, and Ms. Phillips and Ms. Castle showed me around the emergency department how many people were parked out in the hallways in the emergency department. That's a change. That did not used to exist that way when I started out. When I started out, I was at a trauma level 1 hospital. Guess how many beds they had in their ER? 20. And that was because they had an extension piece where they could they could do infusions and stuff. Now you walk into an ER, they all have got like 40 beds plus. I remember the first time I ever walked into a 40-bed hospital, I was like, what is this place? I don't know, I don't recognize a 40-bed ER. It was like overwhelming to me. And now that's like normal, right? And it's going up. It's increasing. So over the course of your lifetime, you can expect to see an increase in use of the ED. There's a lot of things that lead that, right? And then some of them are that there's robots now practicing medicine, right? That you go to your doctor's office and you don't see a doctor, you see a nurse practitioner. All of those things are contributing to the increase in the ED visits as well as things like insurance. Okay, another big shift, and it's not one that doesn't feel as impactful to us, but it's significant because it's a technological shift, has to do with the Human Genome Project. So we will look a little bit at genomics. I'm not going to make quite as big a deal out of it as the textbook does, but I think it is helpful to understand this, that this was a big project. It allowed us to sequence all of the DNA in the human body, as well as look at analysis for that and ethical considerations related to the sequencing of the genome. So genome is that base unit of genetics. So all genes within a particular cell, and that includes both the autosomal chromosomes, the sex chromosomes, and the mitochondria. Did you know that mitochondria are actually a different organism that live inside of our bodies and produce energy? They migrated into our cells at some point in the very, very far distant past, but they have their own genome. So what are we talking about? We're talking about mapping genes to whole chromosomes, right? So here's an example of a sex chromosome, and we've mapped it down to these tiny DNA fragments. That's about all that I'm going to say about that, right? We do need to be aware of it. We need to be aware of what things are genetic. So, something that's going to definitely affect us is all these terms here, and they go back to those morphologic changes, right? Atrophy, decrease in cell size; hypertrophy, increase in cell size; hyperplasia, an increase in the number of cells, right? Metaplasia, conversion of one cell type into another, that would be a cancer process; and dysplasia, abnormal changes in mature cells. So a lot of times before it's labeled cancer, we'll say there's dysplastic changes to this cell, something we can see at the in the lab. So we're in that final objective now of looking at this material, and these are disease classifications. We're going to go through each and every one of them, right? And I'm going to give you now mostly x-ray examples of what these different disease categories look like. So we'll start working on that now. The first is congenital. These are diseases present at birth and result from genetic or environmental factors, right? And that means environmental factors within the mother's and within the womb. So, for example, in Memphis, we have a zip code, I think it's 38103, that has a very high infant mortality rate, right? Leads the nation, I think, or it did in the past. It was associated with things like lead paint, the presence of lead paint, increased stress within the environment, right? Decreased age at the time of the pregnancy. All of those things were environmental factors that affected the infant's ability to be born and to be healthy and things like that. So it's estimated that about 2 to 3% of all live births show one or more congenital diseases. An example of this would be something like Down syndrome.
Do cleft palate fall into this too?
Yes, definitely.
Are these the definitions on the book?
Yes. Okay. Hereditary. Caused by developmental disorders that are genetically transmitted from either a parent to a child through abnormalities of individual disease. An example of that would be hemophilia. So let's look at the effects of hemophilia, right? With Radiopaedia, if you look up hemophilia, you will get this picture here. But again, if you don't have Radiopaedia, that's fine. Okay, inflammatory. This is the disease that results from the body's reaction to a localized injurious agent. So, inflammation affects a lot of things that go on in the body. And there's a lot of different types of inflammatory responses. These can be caused by the invasion of microorganisms, a poisoning of the body substance, or an allergic response. So an example of a possible overreaction to the body's own defenses. And the only reason I have pneumonia down there, it shouldn't be underneath allergic diseases. It's just kind of underneath inflammatory as a whole. And pneumonia is an inflammatory response. So here's an example of what pneumonia looks like on an X-ray image. You don't have to look this one up on Radiopaedia, but I will ask you, where is the pneumonia? It's on the right side. It's actually the right middle lobe, I believe. Because those lobes overlap each other. The fissures of them overlap each other. So what we see is clouding of the lung, but it doesn't quite reach the right costophrenic angle. So there again, it's important for us to be able to identify those costophrenic angles. So again, if I don't know what I'm taking a picture of, how can I get you a good picture? Autoimmune disorders, disease in which the body forms antibodies that injure the patient's own tissues. A great example of this is rheumatoid arthritis. Another example would be something like HIV and AIDS. But here is a classic example of rheumatoid arthritis. So what do we see on this image? Right. There's a total degeneration of the joint space on these images, and yeah. So there's a lot of different forms of arthritis. In arthritis, I'm not going to quite get into the weeds of it yet, but just know that we need to be pretty up on arthritis because the registry loves to ask us questions about the different forms of arthritis, because depending on the type of arthritis we're imaging, it can be either subtractive or additive pathology. So just an FYI about arthritis. It is a big term. Arthritis just means inflammation of the joint. It can be degenerative or not. Now, one other thing to consider is this inflammatory reaction, right? So I'm kind of moving on from classification here, and we're going to kind of talk a little bit about inflammation, just kind of break that out a little bit. So if we have a generalized pathologic, and this is on page 11 and 10, I think, in our textbook. If we have a generalized pathologic process, it's nonspecific, right? This is an inflammatory reaction, right? It can have both local and systemic effects, so it can just be in a particular area, or it can spread throughout the entire body. The whole body could have a fever, or there could just be heat in this one area. It can cause dilation of the capillaries. This increases the permeability of those capillaries, so it's feeding white blood cells and stuff into that area, and it's actually causing the inflammatory response in an attempt to stop the disease. But if we're not careful, this can lead to things like necrosis of healthy tissue. It's trying to break down the disease. It can wind up destroying healthy tissue as well. So here's what that system looks like. There's a chemical injury or a microbial injury or a physical injury, like the person's punched in the face, for example. That would be a physical injury. When they are punched in the face, cells die. They are crushed by the trauma of that punch in the face, right? This cell death results in cellular necrosis, right? And the inflammation is a way to make sure that that necrosis does not spread. It's trying to get rid of the dead cells. It's trying to break down infectious processes that might be occurring. It's trying to repair any break in the skin, things like that. So it's a complex response to that mechanical injury. So these can be really shocking responses, right? This would be an example of an acute inflammation here, right? This big black eye that this person continued fighting while they had, right? An example of chronic inflammation is going to be a process where the inflammation periods are really long, like, for example, lymphedema that follows cancer treatment. But acute inflammation, we often see heat, redness of the skin, swelling, pain, loss of function. This individual can no longer use this eye, right? And elevated body temperature. Yes. Yeah, they're trying to make sure that they don't lose the eye due to inflammation just off the hook. Also, marathon runners, they'll ice their legs after a marathon to reduce inflammation, right? So all of those things, and that boxer went on to continue to have use of that eye, but it requires surgical intervention. They had to slice that area open, drain the inflammation that's occurring because it was crushing the eye. So the body's trying to prevent infection, but the inflammation is just out of control, right? So sometimes it does require surgical intervention.
So what about like when someone has fluid on their knee or ankle or something?
Sometimes that's inflammation, sometimes that's something different, like a fluid within the knee joint or something is different from inflammation. Inflammation has to be based off of the blood, if that makes sense, in the circulatory system. What are things that we do to help with inflammation, right? What are treatments that we have? We use things like tissue regeneration, right? Sometimes that's a graft. We graft skin from a donor, right? Or from a different area of the body. There may be scar tissue that develops in that area. So we may apply stitches to the area in order to reduce the amount of scarring, right? Debridement. And I wanted to give you a pretty gross example of debridement. Debridement is a pretty intense word. If you ever see the word debridement or you know that the patient's going for debridement, like after a burn or something like that, It's a very painful process, right? So one example of debridement is actually using maggots to debride necrotic skin within the wound. It's called maggot debridement therapy, where they'll actually place maggots on the area. The maggots eat the dead cells, and then they remove the maggots. The purpose for this is not to torture the individual, right? Oftentimes this is done under anesthesia. The purpose of this is to get rid of the necrosis in order to initiate the repair process. The necrosis is getting in the way of the repair process. At times it may require remodeling. So that's things like cosmetic surgery that then goes in and tries to make the area look okay again. This is an example of a funeral for an Ebola victim, right? Somewhere in, I think, East Congo. Infection, when we have an infection that results in inflammatory process, the inflammation is an attempt by the body to destroy the microorganism, right? We can have inflammation without an infection. So that guy's black eye is an example of an inflammation without an infection. It's not that he got infected in his eye, he got trauma to his eye, right? But we can also have an infectious process that results in an inflammation, right? The term virulence just relates to the ease with which an organism causes disease. So Ebola is worrisome because it is so virulent. It is so easy to transmit Ebola, right? Okay, other disease classifications. Degenerative, caused by deterioration of the body. So this can be following a traumatic injury, it could be an age process, all of those types of things. Traumatic injury does not necessarily have to do with the individual's age, right? There are things that affect the rate of aging for different parts of the body. So weakening of the arteries or development of plaque in the arteries, that's atherosclerosis, right? That's sometimes related to lifestyle. Individual eats more fatty foods, it leads to more problems within the arteries. So in essence, the arteries are older, right? Osteoarthritis, the breakdown of the bones. So this would be a degenerative process, right, that would result in a decreased need for technique. Now what's interesting, if you look at these two different degenerative processes, both of them are degenerative classifications of disease. But the morphological changes that are occurring are different. One is related to an increased amount of plaque, right, requiring possibly an increased technique, right? The other is causing a breakdown in bony structure, which would require a decrease in technique. So even though they're both degenerating, they do require different. So don't just see degenerative disease and think, oh, that's all subtractive technique. It does require us to put our thinking caps on a little bit. Okay, metabolic disease. Anything that causes a disturbance of normal physiological function. Now the word function is kind of like a flag for me as an x-ray tech. I'm not super interested in function. It's very difficult to image anything functional with an x-ray machine. So if I see metabolic, I just know that ain't me. I can't take pictures of metabolic stuff. The folks who can are down the hall, right? So we're not going to spend as much time on this, but we need to be familiar with it, basically because it's stuff that we don't do. So if we suspect these things, why are you sending them to x-ray or CT? We don't do that. So we kind of need to know it in order to know we don't do it. But endocrine disorders, these are cause disturbances in fluid and electrolyte levels. So things like hypersecretion or insufficient secretion of things. They can be neurological in origin. They can be related to pituitary function. They can be related to thyroid function. They cause dehydration, and it's difficult for the patient to maintain homeostasis because of that disease. But notice, I'm just going to brush by that. I don't have a picture I can show you about an endocrine disorder. Traumatic stuff, you probably have lots of pictures in your mind of traumatic stuff that you've x-rayed. We do a lot of trauma, and so we're going to spend quite a bit of time talking about trauma. But this is either mechanical forces like crushing or twisting, or from the effects of ionizing radiation on the body. So what does that mean? Why would we consider ionizing radiation a form of trauma? Yeah, it can result in a trauma, right? Like if anyone's watched the Chernobyl series, you see the effects very realistically of strange mechanical forces that we have a difficult time understanding. So at one point in the miniseries, he describes it as thousands and thousands of tiny bullets. The radiation is like thousands and thousands of tiny bullets that we've just scattered all over the country, right? So that's a mechanical force. Right? So something to think about it when we get into radiation biology, that what we're talking about is traumatic in nature. But generally we're talking about things like motor vehicle accidents and gunshots, stabbings, fractures, wounds, bruises, contusions, all those fun things. The final thing that we'll talk about is neoplastic diseases. So that would be anything cancerous, either benign or malignant. We'll kind of lump underneath neoplastic. Neoplastic means like a new thing, right? A new thing. So that could be a lesion, which is just a cellular change to disease. That lesion might be a benign neoplasm, meaning it stays fairly localized. It does not spread. Its cells are what we call well differentiated. It looks a lot like the cell that it came from. It's well differentiated. Versus a malignant neoplasm is something that's capable of spread. It's undifferentiated. It means it looks like any cell it wants to look like, and so it's rapidly spreading. And when we talk about metastatic spread, there's a number of ways that cancer can spread. It may be spread through the blood system, so we'll call that hematogenous spread. Lymphatic spread is through the lymph system, which is really common, for example, with breast cancer. Invasion is close spread. So we have breast cancer as the origin. Lymphatic spread to the axilla would be a local invasion. It's spread from the breast to the lymphatics at the axillary area, right? That's local invasion. If it goes from there to then affect other parts of the body like the brain, we would call that seeding. It has moved through the lymphatic system or through the blood system to a distant area. When we talk about neoplastic diseases, again, the word cancer just means various malignant neoplasms. So generally cancer is not used with the word benign, right? It's benign tumor, not benign cancer. Cancer in its general usage implies malignancy. There's basically two forms of cancer that are underneath that umbrella that we will be interested in this class. Carcinomas, those are things that are derived from epithelial tissue. And sarcomas, those are cancers that are derived from connective tissue. And that's all throughout the body. So not just epithelial like the skin, epithelial like the liver, like the lungs, versus connective within those organs. If it's a curative treatment, it means that we would expect if we follow this treatment course, within 5 years we'll be free of the disease. We will show 5 years we're normal, stable. We'll call that curative. If it's palliative, the treatment is designed just to relieve pain and improve quality of life. Our friends in oncology use this T&M system for staging, and it has been around for a long time. So what they're looking at is the size of the tumor. They'll measure it on X-ray or on CT. They'll measure its physical dimensions, its size. Nodal involvement. Do I see involvement within the lymph nodes? Generally, that's either going to require a nuclear medicine examination or contrast injection. And then metastases. Do I see evidence of distant spread? So some of this we're doing in X-ray. The size, we're really good at size. We're good at that in X-ray and CT. The nodal involvement and metastases, generally they're being referred for PET CT now for that. for those measurements. All of that is then assigned a certain number, and that gives us a stage. And the stage determines the prognosis, what the treatment path will be. Stage 1 is generally what you want. That's going to be the easiest treatment with the highest rate of cure. When you get to stage 4, you're generally talking about palliative treatments or hospice. So I don't necessarily want to get into all the weeds of this, but we will be talking some about cancer because it's something for us to be mindful of, right? But in general, we're going to talk about type and grade. So typing I just referred to. We've got an idea of how typing is done. Don't worry so much about the grading. Just know that it's there. There's that scale of 1 to 4. 1, I said we can generally work with a curative measure. 4 is generally going to be a palliative. We can talk about these different forms of invasion, whether it's through the lymphatics or whether it's through the blood system, right? How it spreads or things like that. What we do with the residual tumor. So after treatment, is it what happens afterward? And then ways to facilitate those treatments. You will be seeing these patients, so that's why I want us to be familiar with this term. All right, thank y'all so much.